Hello everyone and welcome to another session of Next Saviours Essential Question Series for NEET PG 2025. Today we are going to have a discussion on lymphomas and how to approach the questions related to lymphomas. At least one to two questions are always going to be there in your examination, and these are going to be a long question. A specific strategy is required in order to answer these kind of the questions, because if you have to divide the questions, then it will be divided into six parts for your identification. Like, the first one is always the age. The second one is whether what is the rate of the growth of the tumor. Then the third one obviously is whether it is nodal or extranodal. And then they will proceed with the B symptoms, that means constitutional symptoms. And on examination findings, there is going to be a provision of the specific feature for that particular diagnosis. But ultimately, you have to make the diagnosis based on the histopathological markers and the immunohistochemical markers, along with the cytogenetic translocations, if at all, are provided to you in the question. So basically, what we are going to talk about is the approach, that how all lymphoma related questions are approached. In order to read the lymphoma question, the first thing that you have to identify is whether it is slow growing or is it aggressive sort of a tumor. Because the T cell tumors, they are usually aggressive, while the classical lymphomas, Hodgkin's lymphoma, they are usually slow growing sort of a tumor. The nodal or extranodal involvement means cervical or extracervical nodal involvement or extranodal, in the sense that there could be involvement of the GI, there could be involvement of the bones, there could be involvement of the mandible or the jaw. So this is how it is going to help you out. Now, what is the age group? As you know, if the child is affected, then possibly you might think about Burkitt's lymphoma. If the elderly is affected, then you have to think about follicular involvement. If there is a middle age group affection, then in that case you have to think about the diffuse large B cell lymphoma and so on. So age is also important for you to reach the diagnosis. Next, after that, once you deal with these first two lines of the question, then ultimately you have to reach the correct answer, and that correct answer is going to be specifically identified on the histopathological image, if at all is given, the cytogenetic translocations, or the immunohistochemical markers. So let's start with the background. You already know about that these lymphomas can be categorized into Hodgkin's and non-Hodgkin's lymphoma. And what are the hints which could be provided? If the middle age group, that means non-extreme age group, is given in the form of young adults, then possibly they are asking about the subtypes of the Hodgkin's lymphoma. While if there are extremes of the age group present, then possibly they are asking about non-Hodgkin's lymphoma, along with some of the other important features that we would be talking about. If at all the Hodgkin's lymphoma, then which subtype of the Hodgkin's lymphoma? Like, you know, that if young female is given, mediastinal mass is given, lacunar cells are provided to you, then most probably the answer would be nodular sclerosis. But if there is a classical Reed-Sternberg cell along with the immunocompromised status of the patient in the form of HIV or eosinophilia, then mixed cellularity type. One-liners are usually asked in relation to the lymphocyte rich having best prognosis, lymphocyte depleted having worse prognosis, and yes, the expression of CD20 positive, which is considered to be a differentiating feature from classical Hodgkin's lymphoma for nodular lymphocytic prominent uh, Hodgkin's lymphoma, along with non-existence of the typical Reed-Sternberg cells, which is seen in case of Hodgkin's. Here, there is a popcorn cell which is identified. So this is just a hint on the basis of which you will come to know that which subtype of the HL could have been asked in this question. We are talking about the first session, that to categorize the question into whether it is about the Hodgkin's or the non-Hodgkin's. Now, as you know, that non-Hodgkin's lymphoma could be of B cell, B lymphocyte origin, or from the T lymphocyte origin, or the NK cell origin. And these T lymphocyte origin tumors are often aggressive, while the B lymphocytes could be variable, and these are the tumors could be differentiated. These are the subtypes which are commonly kept in your examination. But if at all the non-Hodgkin's lymphoma have to be narrowed down, then there are two important key features provided to you in the question. One is the age, and the other one is obviously the site. If the child, then possibly Burkitt lymphoma. In case of young adults, it could be T cell lymphoma or Burkitt's lymphoma. In case of middle age, diffuse large B cell lymphoma or the marginal zone lymphoma. In case of elderly, it could be follicular, the mantle cell, or the chronic lymphocytic leukemia or small lymphocytic lymphoma. So this is how the age is important. And the second thing is the site, that which site is possibly affected. Because if you have to narrow down, as I'm again repeating, if you have to narrow down the differential diagnosis before reaching the cytogenetic markers and the histological features, then you have to narrow down the NHLs by age and site. So if there is involvement of the jaw or the abdomen, like it could be Burkitt's. If there is a GI involvement with H. pylori infection, it is malt. If there is involvement of the skin, you already know it could be Sézary, that is mycosis fungoides. The bone marrow and the blood involvement is seen in case of chronic lymphocytic leukemia, small lymphocytic lymphoma, or in case of adult T cell leukemia or lymphoma. When there is an involvement of the CNS, it is primary CNS lymphoma, which is a subtype of diffuse large B cell lymphoma. So that was first part of our discussion. That means you have to categorize whether the patient is suffering from Hodgkin's or non-Hodgkin's lymphoma, if at all, if it is required in your question. Now, second part obviously is to look for the classical symptoms, if at all provided to you in that particular question. Like, for example, for mycosis fungoides, there has to be a skin lesion provision which is progressing all the way up to erythroderma. In case of Burkitt's lymphoma, there has to be a rapidly growing abdominal mass in case of a child for sporadic cases. For Hodgkin's lymphoma, means classical Hodgkin's lymphoma, there has to be cervical, painless cervical lymphadenopathy, mediastinal lymphadenopathy, the constitutional symptoms, and alcohol induced pain. So these are the specific or the classical features associated with each type of lymphomas. Like in case of chronic lymphocytic leukemia, there is going to be a generalized painless lymphadenopathy in case of elderly, while in case of March syndrome, there will be a GI involvement in the stomach along with the H. pylori infection. In case of adult T cell leukemia or lymphoma, it is very important to be identified that there will be a presence of a skin lesion along with HTL1 endemic. That means the causative agent is HTL1, but there will be an associated hypercalcemia. For nodular sclerotic HL, there is going to be a mediastinal mass in case of young women, and so on. So these are the classical symptoms that you should be knowing about for that particular lymphoma, because if you read the topic individually, then it will appear almost same. But for a specific type of lymphoma, these are the classical features that you should be knowing about, that on the basis of which, at least reading the first 2 3 lines of the question, you can come across to a conclusion before reading the cytogenetic markers. And then finally comes the second part of the question, where there will be a histological finding or the image would be provided along with the specific immunohistochemistry features. Like if you look at the important histological findings which are usually provided to you in the question, like in this case, there is a presence of multilobulated and a folded nuclei, which looks like a popped popcorn. And once you find this image, so this image of popcorn cells, which is also known as lymphocytic and histiocytic variant of Reed-Steinberg cells, and these are the characteristics of the non-lymphocytic prominent Hodgkin's lymphoma. As far as nucleoli is concerned, these nucleoli are inconspicuous. That means they are not that prominent, as it is seen in case of RS, that is Reed-Steinberg cells. So there will be inconspicuous or non-prominent nucleoli, and the cytoplasm obviously is going to be a pale cytoplasm. Now, imagine if this histopathological finding, along with markers, the specific cytochemical markers like CD20 positive and CD45 positive, is provided to you, then obviously you have reached the conclusion. Because in case of classical Hodgkin's lymphoma, there's going to be CD15 positive and CD30 positive, which is not seen in case of nodular lymphocytic prominent Hodgkin's lymphoma. So this is the important slide which is usually kept for the purpose of identification. Now, if you compare the one that we have seen, that is popcorn cells, with the classical Reed-Sternberg cells, then here there is a presence of a large binucleated or multinucleated giant cells. Now, each nucleus has a prominent eosinophilic nucleus, which is giving it a appearance of a owl eye. And there is a presence of abundant cytoplasm, which is often surrounded by a reactive inflammatory background consisting of lymphocytes, eosinophils, and the plasma cells. So, what is there in your image? You can clearly see a binucleated large cell with a large nuclei, giving it a owl eye appearance, and this confirms the Reed-Sternberg morphology. So, it is a feature of classical Hodgkin's lymphoma, right? This is how it is differentiated from the nodular lymphocytic predominant Hodgkin's lymphoma. Another one is the image where you can see that there is a multilobulated or convoluted nuclei which is resembling a flower or a clover leaf. Now, this is found in abnormal T lymphocytes in the peripheral blood smear. And imagine if this finding is coupled with that of the hypercalcemia in the question, and a lytic bone lesion along with the skin involvement, then obviously we are talking about adult T cell leukemia or the lymphoma, which is caused by human T lymphocyte virus type 1. The flower shaped or the clover shaped nuclei, these are classically associated with adult T cell leukemia or lymphoma. And this image in particular is very, very commonly asked. Now, in this case, as you know that Burkitt's lymphoma related questions, they usually highlight a histopathological image, giving it a starry sky appearance. Now, what is a sky here in this image? It is a deeply basophilic background of dense proliferative tumor cells, which are obviously the Burkitt cells. So, this is the sky. And so, as you can see, that deeply basophilic background of dense proliferating tumor cells, which is Burkitt cells. And what are the stars in this case? These are numerous tangible body, which are the macrophages. So these are the basically these are the macrophages with ingested apoptotic debris, and they are appearing as a pale round space. So these are the stars, and this is how it gets its feature. That is a starry sky appearance. Starry sky appearance is the feature of Burkitt's lymphoma. Now, here in this case, as you can very clearly see, that deeply folded, convoluted, or brain like, that means cerebriform appearance, is a feature of mycosis fungoides. So, these are basically the cutaneous T cell lymphomas where there is a presence of a cribriform or cerebriform nuclei which are characteristic of the Sézary cells. Now, there are other histological findings, like in case of chronic lymphocytic leukemia, where you see numerous smudge cells, which are pale, irregular, ghost-like fragments. So there are multiple of these histopathological findings on the basis of which you can conclude the answer. All right, it helps you in making out the answer. So let's see what are the clues that could be provided to you in the question, and then what you have to think of. Like, as we know that owl eye nucleoli is a feature of classical Hodgkin's lymphoma, that is Reed-Sternberg cells. The popcorn cells are the features of NLPHL, that is nodular lymphocyte prominent Hodgkin's lymphoma. The starry sky appearance is a feature of Burkitt lymphoma. The smudge cells are seen in case of CLL. Back-to-back follicles is a feature of follicular lymphoma. Cribriform nuclei, that means brain-shaped nuclei, is a feature of mycosis fungoides or the uh, Sézary syndrome. The tangible body macrophage is again a feature of Burkitt lymphoma, which are appearing like stars in the sky. The lymphoepithelial lesions is a feature of Malt lymphoma, and so on. So these are the clues which could be provided to you in the question and as a fourth segment. And then finally, in order for you to conclude to the diagnosis, they are providing you a molecular marker or the immunophenotype if at all cytogenetic abnormality is not present. Now, out of this table could be the question itself, then that they give you some of the clinical features, the histopathological features, and then they will ask you that what is a likely cytogenetic abnormality, or they can give you these abnormalities in the question itself, and then they will ask you what is the answer for that particular question. So, as you can very clearly see that in case of classical Hodgkin's lymphoma, the NLPHL, the mycosis fungoides, and adult T-cell leukemia or lymphoma, there is no specific translocation. So, the question would be basically asked from their markers in the form of immunophenotype. That means immunohistochemical markers. Like in case of classical Hodgkin's lymphoma, it is expression of the CD15 and CD30. But that CD15 and CD30 would be negative in case of nodular lymphocyte predominant Hodgkin's lymphoma. Similarly, in case of mycosis fungoides, there's going to be CD3 and CD4, that is T help cell positivity, along with the TCR rearrangement. While in case of adult T cell leukemia or lymphoma, the most important or the most critical finding which is provided or which could be provided to you is the causative agent itself, that is HTLV1. Now, in case of Burkitt's lymphoma, there are so many specific markers on the basis of which you can mark the answer. Like T814 is the most common cytogenetic abnormality in the form of translocations. The CMYC overexpression, and along with the immunohistochemical marker positivity in the form of CD10, CD20, BCL6, and Ki67. While in case of follicular lymphoma, the translocations are usually T1418 and T1114 for mantle cell lymphoma. There will be an overexpression of BCL2 in case of follicular lymphoma, while cyclin overexpression, that is cyclin D1 gene overexpression, in case of mantle cell lymphoma. Now, diffuse large B cell lymphoma is identified as a non-consistent translocation that can have BCL6, BCL2, MYC rearrangement, along with the CD20, BCL6, and BCL2 positivity. Then the mild lymphoma is usually identified by the translocations of T1118 and T1418. Chronic lymphocytic leukemia, having a deletion of a long arm of the chromosome number 13, which is associated with the good prognosis, and rest is associated with the poor prognosis. The overexpression of BCL2, not along with the T14 translocation, cytogenetic translocation. This is how you will differentiate it from the follicular lymphoma, and the presence of the immunohistochemical markers. So this is the final part of your question on the basis of which you will mark the answer for the particular lymphoma related question. Now, in order to summarize what all we have studied, now what specifically would be provided to you for each and every lymphoma type in the question? For classical Hodgkin's lymphoma, carefully the RS cells in a mixed inflammatory background, and the keywords or the MCQ clues would be a large binucleate cells with out ion nuclei with the expression of CD15 and 30 positivity. In the clinical features, there is going to be a presence of nodal enlargement in the young adult age group. For nodular sclerosis, there is going to be a presence of RS cells, which is often lacunar variant with fibrous band forming nodules. But here, the keywords are going to be the lacunar mass, the mediastinal mass, and the involvement in case of young women. Now, in case of mixed cellularity, there will be many eosinophils along with the classical RS cells, which is common in immunocompromised patient, that is HIV patients. For lymphocytic depleted CHL, there will be presence of numerous RS cells with a scant lymphocytes, because of which there is a presence of poor prognosis. So it is a poor prognostic subtype associated with immunocompromised status of the patient, or is seen in case of elderly. For nodular lymphocyte predominant, as we have already seen, that instead of RS cells, there is going to be a presence of popcorn cells. And instead of expression of CD15 and 90, there will be expression of the CD20 and CD45 positivity. The diffuse large B cell lymphoma is identified as the presence of sheets of large lymphoid cells with the vesicular nuclei and prominent nucleoli, with a diffuse growth pattern, with the positivity of their specific markers, and these are considered to be the aggressive type of the tumors. For follicular lymphoma, there will be nodular follicular architecture with the centrocyte and centroblasts, which is a histological hallmark. But for MCQs, there is going to be a provision of cytogenetic abnormality of T14 and 18. Burkitt's lymphoma, we have already seen so many specific findings on the basis of which you can easily mark the answer, and that is the reason why Burkitt's lymphoma is one of the most commonly asked lymphomas. For mantle cell lymphoma, they usually give you a cyclin D1 positivity along with the monomorphic small or medium cell lymphoid cells which is surrounding the follicles as a histological features. For marginal zone lymphoma, you need not to worry about because there will be an association of the HI, there will be association with the H. pylori and the gastric mucosal involvement. For chronic lymphocytic leukemia, there is going to be a smudge cell present in the blood and the proliferation centers in the nodes, along with the specific markers of CD5 and CD23 with the trisomy 12 or deletion of the long arm of 13 chromosome. Mycosis fungoides, again, very easy for you to identify that on the basis of their clinical appearances, there is going to be a portier microabscesses with the CD4 plus T cells. In the histology, in the biopsy finding, there's going to be a presence of the brain-like nuclei, that is cerebriform nuclei. There will be a presence of cerebriform nuclei. So this is in a nutshell to summarize. Now, once we have studied about how to approach the questions related to these particular topics, let's start with the question that was presented to you in the beginning. Now, if you look at this question, that a 58-year-old male presents with a rapidly enlarging painless mass in the right cervical region over the last 2 weeks. Now, there are three key features which you can identify. The first one is the nodal involvement. The second one is the aggressive involvement because in the last 2 weeks, and the age group which is elderly. So in this case, there is a cervical lymphadenopathy. That means there will be a nodal involvement. Rapid growth because it is seen within 2 weeks, along with the constitutional features like there is a unintentional weight loss over the last 3 months. So it is rapidly growing kind of the tumor, and the age is that of the elderly. Now, this already makes you think of an aggressive adult lymphoma. So most likely, it could be a DLBCL. That means diffuse large B cell lymphoma, but you have not concluded the diagnosis yet. Now, look at the key histology and their markers. Now, if you look at the biopsy findings, like excisional biopsy of the node reveals sheets of large lymphoids with a prominent nucleoli and a high mitotic activity. So, this confirms that you are dealing with the answer of diffuse large B cell lymphoma, and also there is a positivity of CD20 and BL6 with no characteristic translocation. So answer for that question is very simple. At this point also you have to rule out why not Burkitt lymphoma, because Burkitt lymphoma is usually seen in case of young individuals. Now it usually involves, there has to be an extranodal involvement like jaw involvement in case of endemic lymphomas, or abdominal involvement in case of sporadic lymphomas, while the histological features, as you know, starry sky appearance has to be there, and the cytogenetic abnormality of T1814 translocation involving CMYC gene has to be there, but it is not there obviously. So this option, that is Burkitt's lymphoma, is incorrect. Now if you look at another option like option number C, that is Hodgkin's lymphoma, that is nodular sclerotic type. Now you already know that it is more common in case of young women, which is over here is a elderly male, and it presents with the mediastinal mass. Now young women mediastinal mass, then think of this nodular sclerotic type of Hodgkin's lymphoma. And the histology also would have been provided the presence of the RS cells and the markers in the form of CD15 and CD30, which is usually not present over here. So this this nodular sclerotic type of the Hodgkin's lymphoma is also ruled out. And then finally is the follicular lymphoma. As you know, the follicular lymphomas are slowly growing tumor. These are not rapidly growing tumor. These are indolent, slowly progressive over 1 to 2 years. And it is also common in elderly, though it is common in elderly, but there is a presence of generalized lymphadenopathy. And the histology obviously would be showing a centrocytes and centroblast in the follicular pattern. And the immunohistochemical markers would be presented like CD10 or BCL2, right? So here there is no such thing provided to you in the question, and answer for that question is diffuse large B cell lymphoma. Let's see other examples like how you can immediately jump to the answer when you are ready with the approach. Like A 6-year-old African boy with a large jaw mass, very fast growing. Biopsy shows starry sky appearance and T8 to 14 cytogenetic translocation is detected. Then obviously the answer for this question is Burkitt's lymphoma. You need not to have a second thought related to this. Like jaw mass, very fast growing. Biopsy shows starry sky appearance. What else is required for you to mark the correct answer? Next is 65-year-old women with slowly growing generalized lymphadenopathy for months. That means age 65, that means elderly. Slowly growing generalized lymphadenopathy for months, no fever or weight loss. Biopsy shows centrocytes, and there will be a involvement of T14, 18 with BCL2 positivity. Answer for that question is follicular lymphoma, right? So, whenever there is a slow growing tumor, in case of elderly, along with T14, 18 cytogenetic translocation, then think of follicular lymphomas. Let's take another example. Like a 55-year-old man with H. pylori infection now has a gastric mass. Biopsy confirms the marginal B cell lymphoma. What else is required for you to answer this? That it is malt lymphoma. So these are the hints that you have to catch immediately in the question once you are ready with the diagnostic features. So obviously, once you have this mild lymphoma, then you have to treat with H. pylori eradication initially. Then coming on to the next question, a 60-year-old man with GI involvement, splenomegaly, and lymphadenopathy. Biopsy shows cyclin D1 positivity and a specific cytogenetic translocation of T11 to 14. The answer for that question, obviously, is the mantle cell lymphoma. So, not difficult. Look at another example. Like a 70-year-old man with fatigue and lymphadenopathy, CBC shows lymphocytosis, smear shows smudge cells. And when you see the word smudge cells along with CD5 and CD23 expression on immunohistochemistry, then obviously the answer for this question is chronic lymphocytic leukemia or small lymphocytic lymphoma. A middle-aged man with slowly progressing rash showing plaques with a generalized skin redness, that is erythroderma, and the peripheral smear shows cerebriform nuclei. What else is required for you to make the diagnosis of mycosis fungoides? And then finally, a Caribbean woman with a skin lesion, hypercalcemia is there, and lymphadenopathy is present with the positivity of HTL1. Answer for that question is adult T cell leukemia or lymphoma. So that is the answer for this question, and this is how we have revised it. Hope the session was of help. Now, particularly for the FMGE students, you are not getting one question, you are getting 3 to 4 questions out of this topic. And this table in particular is very, very important for you to remember. Remember these buzzwords whenever these are presented to you in the question, a long question, then immediately you can jump onto the diagnosis related to that particular finding. So all the best for your future examinations. All you MBBS students, the NEET PG 2025 Essential Question Series is already launched on our next Saviours platform, which is available on both the Android, that is Play Store app, and the iPhone, that is iOS. What this app is all about, or what this set of question is all about, to make you practice the question which specifically are asked in the examination, and these are the set of the questions that you cannot afford to mark them wrong. A specific strategy is required before sitting in the examination. Earlier you get adapted to that strategy, easier for you to uh, go through that examination. So all the best for your future examination. Please join our Telegram group. The link is provided to you in the description. All the best.